Hello, my name is Shelby Arena, and I'm the Harm Reduction Manager here at Matters. Today, we'll be talking about Harm Reduction 101. Our learning objectives will be to understand the history and principles of harm reduction, to dive a little more deeply about the dangers of fentanyl and xylazine contaminating our drug supply, and to explore the future of harm reduction. When we talk about harm reduction, most folks immediately think about people who use drugs. But in reality, everyone uses harm reduction in their everyday lives. Riding in a car is something that can be inherently risky. There's always the chance of an automobile accident, but wearing a seatbelt is something that mitigates some of those risks associated with a dangerous behavior. There are many examples of everyday harm reduction that folks use in their daily lives. To set the stage for our discussion on harm reduction, I want to introduce two different frameworks. The first framework is the continuum of substance use. As you can see, this continuum starts at someone who is a non-user or is abstinent from substance use and progresses all the way to chaotic use. In between, we have experimental use, maybe someone who is curious about a substance, has tried it once or twice. Then we move along to recreational use, maybe someone who uses on their birthday or holidays, special occasions, things like that. Then we move towards regular use, maybe someone who uses on a weekly basis or on the weekends. This next step, misuse, and then problematic use and chaotic use, this is the end of the spectrum where that substance use really starts to interrupt someone's daily life. In this area is where you will see people who qualify for a substance use disorder diagnosis. But as you can see, this is just the very end of the spectrum. Previous to that, these are all folks who engage in substance use who do not qualify for a substance use disorder where their substance use is not impacting their daily life. We do know with contaminants like fentanyl and xylazine in the drug supply, though, that even if your substance use is not rising to the level of a disorder, if it's not impacting your daily life, you still are at risk for some of the negative consequences associated with substance use. The second framework I would like to introduce to set the stage for this discussion is the trans-theoretical model of behavior change. This model conceptualizes behavior change as a series of 6 stages that a person moves through. This model is flexible and can be nonlinear, so people can bounce back and forth between stages. The first stage is pre-contemplation. This is someone who has no intention of changing their behavior. They might not even realize that they have a behavior that is negatively impacting their life. The next step is contemplation. This is when a person is aware a problem exists, but they're not really ready to address it yet. Next is preparation. This is where someone is taking the steps to get ready to address that problem. If it's a substance use disorder, maybe this is where they are looking up clinics in their area or checking on their insurance status. And then that next step is action. This is where someone is actively engaged in modifying that behavior. Again, with substance use disorder, this could be someone who is engaged in treatment. They are on a medication. They are actively going to counseling. And then this last step here is maintenance. This is where we're sustaining that behavior change. Easier said than done. The maintenance phase is the most difficult and usually longest stage of this cycle. I think sometimes folks think once they get to that point where they have successfully stopped their drug use, they've been engaged in treatment for some time, they've reached the finish line. But really, maintenance takes work and it takes a community. This next step here, relapse. A lot of folks don't include relapse on this model of behavior change, but we think it's very important because it's very normal and common for someone to relapse or fall back into those patterns of their old behavior. One thing to note here is that as folks are jumping back into this cycle and repeating steps, we like to look at it as an upward spiral. So instead of someone running in circles and repeating the same steps over and over again, we look at it as an upward spiral where someone is learning from each relapse. So each time they jump back into this cycle of change, each step is a little bit easier. The pre-contemplation phase, they know that there's a behavior that they need to change because they've already tried to change it before. The preparation stage, they already know what clinic they like, what type of treatment works for them. And so each time it does get a little bit easier and easier to work towards that stage of recovery or maintenance. We discussed the frameworks that this conversation takes place in, and now I want to provide some context on the current state of the opioid crisis. To start, let's define opioids. Opioids are natural or synthetic substances that act on the brain. They're usually prescribed to treat persistent or severe pain following surgeries, injuries, or cancers. Of course, opioids can also be used illicitly. Opioids are extremely addictive, and taking too many can lead to an overdose or even a death. Fentanyl is one of the main drivers of our current opioid crisis. Fentanyl can be prescribed medically and is also found illicitly. In the illicit drug supply, fentanyl is most commonly mixed into heroin, but it is also found in other drugs such as cocaine, meth, and counterfeit pills. Fentanyl is extremely potent, 30 to 50 times more potent than heroin and 80 to 100 times more potent than morphine. You cannot overdose simply by touching powdered fentanyl. This is a common myth. To highlight some of the differences between medical fentanyl and street fentanyl are important. Medical fentanyl has safety precautions in place. There are less side effects using fentanyl than other opioids. There are also alternative routes of administration, like nasal routes or a skin patch. Fentanyl is the preferred opioid pain medication in many medical situations. On the other hand, we have street fentanyl. There are no safety precautions with street fentanyl. It is often concentrated doses, or you're not sure what the dose is. Additionally, street fentanyl is often contaminated with other substances. This small amount of fentanyl can be lethal to someone who does not have a built-up tolerance in their system. The next drug I'd like to highlight is xylazine. You might have heard it called Tranq. Xylazine is a medication that was developed in the early 60s by Bayer Pharmaceuticals as an antihypertensive. These medical trials stopped pretty quickly in humans because the medication was way too powerful and caused central nervous system depression. The medication was then switched over to studies for veterinary use and was later FDA approved. This medication is a sedative and a tranquilizer. It lowers levels of consciousness, blood pressure, and respiration. Because xylazine is an FDA-approved veterinary medicine, it can be purchased on various websites that sell research chemicals. There is also a high level of diversion from veterinary clinics and farms. Xylazine first appeared in the illicit drug supply in Puerto Rico in the early 2000s. The Philadelphia Medical Examiner's Office has included xylazine in toxicology reports beginning in 2006. It has been present, especially in the Kensington area of Philadelphia, since the early 2000s, and it's been present in Camden, New Jersey as well. It has been increasingly found in the drug supply across the United States, and it's becoming more prevalent in New York State. In 2023, 13 of the 298 overdose deaths in Erie County, New York, contained xylazine. It is believed that xylazine is added into the illicit drug supply because it may prolong the effects of fentanyl, the desired effects and undesired effects. It is important to note that xylazine is not an opioid, so it does not respond to naloxone. In most cases, xylazine is also combined with fentanyl, so if you suspect that someone is experiencing a xylazine-related overdose, it's always best practice to administer naloxone, as there is more than likely fentanyl or opioids in that person's system. As you can see by Figure 2, the rates of xylazine in the U.S. drug supply are rapidly increasing. An additional thing to note about xylazine is the experience of skin wounds from folks who use this substance or use substances contaminated with xylazine. Xylazine-related skin wounds can occur regardless of method of consumption. They're not strictly associated with injection sites. Because skin wounds can be found on other parts of the body, some individuals do not associate these wounds with their drug use. So next we will show some images of xylazine-related skin wounds. We do not show these wounds just for the shock factor, but because, like I said, many folks do not associate these wounds with their drug use, so it's important to be able to recognize what these wounds look like to assist people in seeking proper healthcare services. I'll be moving to the next slide. If you'd like to look away, I'll let you know when the slide has changed. So xylazine wounds are mostly found on the arms and legs. They usually start out as small punch hole wounds, appearing in a cluster and then blend into a single large wound. These wounds are not typically pus-filled, so antibiotics are not normally needed if there's no infection present. It's important to note that these wounds may expand rapidly and lead to amputation if not addressed early. Now we will talk about the history of harm reduction. Harm reduction really found its foundation in the social movements of the 60s, 70s, 80s, and 90s. The Black Panther Manifesto explicitly demanded free health care for all Black and oppressed people. The Young Lords had their 7 demands for Lincoln Hospital, which included treatment for addiction and preventative care programs. ACT UP advocated for a more robust and proactive response to the HIV and AIDS epidemic of the 90s. In 1981, we had the first confirmed HIV diagnosis for a person who injected drugs in San Francisco. That is when we really started to see the proliferation of syringe exchange programs to provide new syringes so folks did not have to share. Those first popped up in Europe in 1985. A harm reduction pioneer from the U.S., Edith Springer, visited both of those sites and returned to the U.S. to co-found the harm reduction movement here. In 1999 is when we saw the first wave of the opioid crisis. Areas like New England and Appalachia were severely impacted because OxyContin was marketed as less addictive, and the marketing was heavily saturated in low-income and rural areas. In Europe, we saw the introduction of safe consumption sites in the late 80s. Safe consumption sites are places where someone can go to use their substances in a safe and monitored location with access to sterile syringes as well as overdose prevention supplies. In the U.S., safe consumption sites are federally illegal. We do have one in New York City operating in a kind of legal gray area. In around 2005, we saw HIV transmissions among people who inject drugs begin to decline, and so the harm reduction focus shifted away from HIV and AIDS to Hep C and overdose prevention. That's when we saw the legalization of naloxone for non-medical personnel. Prior to that, you had to be a medical professional in order to obtain and use naloxone. We also saw the introduction of Good Samaritan laws. New Mexico was the first state to pass a Good Samaritan law. New York State got their Good Samaritan law in 2011. And these are laws that protect the person who overdosed as well as the person who calls 911 and helps to encourage those folks to call 911 at the scene of an overdose. In 2010 is when we saw the second wave of the opioid crisis, really defined by the rise in overdose deaths associated with heroin. At this point, we had really clamped down on prescribing of OxyContin and other opioid prescriptions, and many of those folks turned to illicit opioids like heroin. Around 2013 and later is when we start to see the third wave of the opioid crisis. And this is a rise in synthetic opioid deaths related to fentanyl in the drug supply. Many people are now talking about a fourth wave of the opioid crisis that really started around 2020. And this is defined by polysubstance overdoses, where folks are overdosing with not only opioids in their system, but other substances like cocaine and meth. Over the last 15 years or so, harm reduction has become a more cohesive movement, and now it's guided by a set of 6 principles. The first is participant-centered services. This is really the non-judgmental and non-coercive provision of services and resources to those participants. The next is participant involvement. This principle ensures people have a real voice in the creation of programs and policies designed to serve them. Many times you'll hear the phrase, "nothing about us without us." The next is participant autonomy. This principle affirms people who use drugs themselves as their own primary agents of change. Next is pragmatism and realism. Many opponents of harm reduction say that harm reduction is enabling drug use. This principle shows that harm reduction does not attempt to minimize or ignore the real and tragic harm and danger associated with licit and illicit drug use or other risk behaviors. The next principle is culturally informed. This recognizes the various social inequalities which affect both people's vulnerability to and capacity for effectively dealing with potential harm. The last principle is health and dignity. This means that when evaluating the success of a program or policy, the quality of individual and community life and well-being is the criteria or ultimate goal for success. We currently have many different categories of harm reduction strategies. The first is safer drug use. These are techniques or methods that folks who use drugs can use to reduce their risk of overdose. Something like using low and slow, using a smaller amount, making sure that you're using with a friend who has naloxone, and testing your supply. Overdose prevention includes understanding the risks for overdosing, knowing the signs of overdosing, being aware of any Good Samaritan laws in your state, and programs that distribute Narcan and train folks on how to use it. Another harm reduction strategy is medication for opioid use disorder. There are many different medications and different ways to access this medication. Finally, are syringe exchange programs. These are places not only where you can get sterile supplies and drug testing supplies, but they're also a place for community support. Many syringe exchange programs are able to link and refer their participants to other healthcare and supportive services. Currently, Matters provides opioid overdose response training and naloxone distribution, as well as the distribution of xylazine and fentanyl test strips. All of these supplies can be ordered through our website or accessed via our harm reduction vending machines. The last thing I'd like to touch about is the future of harm reduction. We discussed safe consumption sites, and many folks in different areas are trying to expand their use in the U.S. Another concept is called safer supply. This is where a prescriber can prescribe medications to someone who uses drugs as a safer alternative to the illicit drug supply. Usually this is reserved for people who are at the highest risk of overdose. Matters has distributed 15 harm reduction vending machines throughout the state, which will provide fentanyl and xylazine test strips as well as naloxone. You can access this map to find a vending machine near you on our website at www.mattersnetwork.org. Another concept we like to talk about when we talk about harm reduction is the concept of stigma and person-centered language. The language that you use when interacting with a participant is very important. We always want to recognize that a person is a person first, and behavior is something that can change. So when we define someone by their behavior by calling them a drug addict or a user, it implies that they're something instead of someone. We know that stigma is a barrier to care, and we want people to feel comfortable when accessing our services. We want to recognize that people are more than their drug use, and harm reduction is a holistic approach. This hyperlink here provides a resource for a language guide that can help you recognize when you might be using stigmatizing language. And here is a brief video that goes a little bit deeper into the language that we use.
Words can become grenades, strategically spoken at times to do the most damage. And when those words come from family and friends, they cut deeper. Labels erased my humanity. Total strangers felt allowed to criticize or judge me, saying that I was just a drunk or addict. These words also carried the connotation that I was lazy, selfish, or a criminal. After a while, I began to believe the words, concluding I no longer served a purpose or deserved hope. Luckily for me, these feelings were eventually replaced with words that provided healing.
The research is clear. Not only do words shape how we view people, but words also shape how we treat them. For example, studies show that when someone is described as an abuser or addict, the general public and even clinicians are more likely to believe that they should receive punishment over treatment. Tragically, for those with addiction who are looking to lead fulfilling lives, hearing the terms drug abuse or addict is paralyzing and demotivating. It blames people for their own illness, ignoring environmental and genetic factors. It feeds into the stigma they experience from society, their family, and treatment providers. To help decrease stigma around language, the Office of National Drug Control Policy recommends using person-first language to replace judgmental and negative terms. For example, a person with a chronic medical illness that impacts their brain is not an abuser or an addict. They are John with a substance use disorder. John, a person who requires treatment and support to recover from his illness. Words matter. They can hurt and reduce someone's motivation.
Together, let's choose supportive, non-judgmental words that lead to treating people with respect and compassion.
So after reviewing that, I like to ask, what can you do to reduce stigma? These are some questions you can ask yourself. Are you using first-person language? Are you mixing up someone who just uses substances and someone who qualifies for a diagnosable substance use disorder? Are you using sensational or fear-based language? For example, when referring to xylazine, we want to say xylazine, not the zombie drug like it can be portrayed on the news. Are you using technical language with a single clear-cut meaning instead of common terms or words with inconsistent definitions? For example, when referring to an overdose, someone becomes unconscious. Avoid using passed out, as this can mean different things to different people. Are you unintentionally perpetuating drug-related moral panic? We know the news sensationalizes drug use. Make sure you are checking your sources and vetting information before sharing to avoid further perpetuating fear and misinformation. Additionally, research provides a strong evidence base regarding the feasibility, effectiveness, and cost-effectiveness of harm reduction approaches. If you want to help your community now, you can get trained in carrying naloxone, order test strips here, and learn more about the Matters Referral Network. Additionally, here are some resources to dive deeper into some of the topics we discussed today. The first is a YouTube video that talks about On Point, the first and only supervised consumption site in the US, as well as Safer Supply, the concept of prescription opioids for people with opioid use disorder at a clinic based in Vancouver. The other links here are regarding stigma and the impact that language can have on health outcomes. Thank you so much for listening to my presentation. If you have any questions, please reach out at info@mattersnetwork.org.